So Sublocade is the injectable form of Suboxone. Suboxone does work really, really well. But the difficulty with Suboxone is getting the person up to the dose where they can manage on it and end up leaving the hospital or leaving the area where I'm working with them and having it all be successful. So Suboxone is great. Sublocade takes away the barriers that are otherwise inherent in some of the other OAT considerations. The biggest thing about Suboxone that helps, actually, why don't I just go to the evidence first, or to the thing, is that of the people in my clinic, in my area, of the people that are on Suboxone, more than like 80 to 90% stay on it and are successful. Whereas with Suboxone, methadone, things like that, there's success, but it goes up and down and goes back and forth. It's not always there, and that's dependent on many, many different kind of things. But the Sublocade is crazy successful. It's successful in a number of different ways. One is that when you have the injection, and it's in you, and it's in your like subcutaneous fat in your belly. Not that any of us have any of that, but if there is some there, then it slowly releases over 28 days, which means if you have a gastroenteritis and you miss 3 days worth, you aren't suddenly cut off at the pharmacy and have nothing. If you need to go to a funeral, you don't have to suddenly say, oh man, I had to leave and I couldn't get my prescription transferred. If you decide to go to a party and you end up partying for a bunch of days, it's still a slow release. You still are covered for it. If you decide that the roads are too slippery or icy, you're still covered for it. So there's so many different situations whereby the Sublocade is a really good option. The other part of it is that if at a point in your life, the way you got from day to day was to make money by doing things that you otherwise wouldn't want to do, like sticking your mouth over a penis that has pus-filled scabs on it. You get a mouthful of scabs and pus in your mouth in order to make $5 or $10. You don't have to remember that anymore by taking the Suboxone every single day. You don't have to think about the ways you took money from people that you otherwise wouldn't have taken money from, or that you used up your personal finances, or how you lost relationships or friends or anything like that. I've come to realize that the methadone, Suboxone, taking it every single day blocks your receptors, but it reminds you of a life you used to have. And a lot of the people that take the Suboxone say to me, I can forget that I used to have a life that I didn't want to have. And that's powerful. That's a really, really good thing to do. So that's why I'm so positive about Sublocade, is that it helps not only with the physical withdrawals, but it also helps with the emotional context of letting go the things that remind you or trigger you into being unhappy or sad about the things that you wish that maybe had been different. So how do we get there? First thing is to recognize whether or not the people even need it. And that comes in many different places. That can come and emerge in terms of recognition of, you're here for a broken leg. Do you need help? In terms of substances or anything else? We notice that you have or you don't have to say it, but you could notice that there's poor dental hygiene. You could notice that there's skin breakdown. You could notice that there's other things that give you a hint that there could be some substance use. It doesn't prove it is, but it gives a hint. The point of this is not that you're trying to ask them to say, I have a substance use concern. The point is you're asking them to say, do I need help while I'm here so I don't go through withdrawals? It avoids the admission or recognition or something that things could have been different. And it just goes straight to the benefit of, I'm not going to feel sick while I'm here. If if we ask the questions in such a way that we can get to that important point, then it's an immediate consult to the addiction medicine consult service from Emerge, from surgery, from whatever. Because some people, of course, are going to have to come in for a gallbladder or for a resection of some bowel for diverticulitis or something. They're going to be in here for a few days. Well, knowing that they're going to need something beforehand gives me an opportunity to have a conversation. A lot of these individuals, some of them overdose and some of them are run to Emerge and we know who they are. Others we don't know. Others are individuals for whom they have it in quote unquote control. They have a certain amount, they get it from a certain person, they use a certain amount per day, nobody else knows. But if you come in here for 3 days, the person that supplies you is not going to come in here and give it to you. And if you bring it in yourself, you're going to have to somehow figure out a way of getting that supply, and that might not work out so well. So you're going to go through withdrawals if you don't use every day. And that's where, if for instance a person comes in for a surgery they're going to be in here for a few days afterwards, the initial consult to me to help them not only beforehand but also afterwards means that we might have a lifetime of an individual no longer needing to buy off the street. So we can take examples of people that through another reason need to ask for help or want to ask for help, but we can also use it as people that overdose and go into kidney failure, so they're in the ICU, or people that have a sepsis and their leg is so bad that they need to be in the hospital for a while. All those situations are just opportunities to try to develop a relationship, to then say things can be better. Now that's my responsibility, or any other person that wants to take this on. That's their responsibility to develop that relationship. And upon developing that relationship, then the individual has an opportunity to say that they do want things to be better. And then we talk about how do we want things to be better. Now, sometimes that might be just a matter of harm reduction. So it might be just a matter of dilaudid every day, so they use less. Which means if they think they're buying fentanyl, they might be buying fentanyl with benzos and then die because it suppresses their respiratory, and Narcan's not going to bring back a benzo overdose, so they just die. So safe supply helps with those individuals. But there might be individuals that say, you know what, I don't want to use at all. I want to not have to buy. So I want to go on either Suboxone or methadone or Dilaudid. Now some of those individuals are going to have pain concerns, which does influence which ones that I would choose, because I have to choose something that is a combination of pain, benefit, and overdose and substance use benefit. So there are nuances in terms of which ones would work best for which individuals. But really, that's what I have to figure out. First step is to figure out they didn't need anything at all. And that's where this board up there comes in every day at 10 o'clock when you guys do it. Is you go through all the patients and you say which ones are potential for needing, that are going to either leave against medical advice, or we have an opportunity, a golden opportunity to make things better, or whatever. Now, that's one of the situations. Some people though come into Emerge and they get released from Emerge. It'd be nice if those individuals were recognized as well, because there are situations whereby the clinical acumen of what likely is going on is going to be associated with substance use, and it'd be good if those consults came through as well from Emerge. The path that I would see going forward with this, one would be, as I said, the recognition that interviewing the individual and potentially testing the individual with a UDS, especially if it's combined with another urine screen, would be a really good way of at least screening to see if a consult is a good idea. But Another part of it is trying to see if we can do it early enough whereby I can get them out of the hospital on a stable protocol. So I've been becoming more and more aggressive in terms of how quickly I get people up to, for instance, Sublocade. And as I'm doing it now, if someone comes in at 10 o'clock on a Monday morning, I can get them on Sublocade by Tuesday afternoon. It's really fast now. Now, I do have to be careful, and I do have to choose which individuals, but there's a lot of individuals that I can go that fast. We're looking at a 2-day turnaround from having to buy, having to find the funds to be able to afford the product, having to choose behavior and choices in order to make the funds in order to avoid the product. So we're looking at someone who is, for which their choices are really out of their control because of the risk of withdrawal, to a point where they don't need to make those choices anymore in 36 hours. And that's, I think, worth an admission. If nothing else, just for that one reason. Because that individual, should they not be making those decisions, is less likely to go into a diabetic ketoacidosis because they don't take their insulin for 3 days. They're less likely to have a leg cellulitis because they don't pay attention to the leg for an infection for a number of days. They're less likely to be involved in traumas or in other sort of other things that would predispose them to an admission unrelated, well, not unrelated, but just not directly related to the substance use. So we could cut down on admissions, we could cut down on length of stay, we could cut down on healthcare system overall by addressing the opportunity to see the individuals that could benefit the most from an early intervention of opioid agonist therapy. So anyway, that's the biggest thing that I wanted to talk about, is how exciting Sublocade is right now and the path towards it. Not everyone's going to go there. Some people. Sorry, go ahead.
Is it just is it 3 to 4 days of an admission? Is that what you're thinking? Depending on the individual?
Depending on the individual, it could even be one night.
Right.
It could be.
And do you think if we had one bed always reserved for you, would that work, or do you need like a couple of beds?
No, one bed would be fine, because I mean, I have in my phone right now, I have in my notes area, I have a list of patients that are asking or not every day, but many days for an admission in order to be on OAT. I have no beds for them. So I have those. They're on my phone.
It'd be nice if we could just give you one bed, because the times that we've saved you a bed, they haven't come, and then I run into crunch. But if we just have one bed dedicated for it,
could you do it in sight, like one bed stayed in sight?
You know, would that be a conversation with you? And sometimes we explode there. But I think if we had one bed that we could just dedicate, and that's all it is, it doesn't get used for anything else.
But I could even give you a heads up that I'm not going to need a bed for a little while because I have no one on my list.
Right.
But I mean, I have 4 on my list right now that want in, and I have no way of getting them in.
But if they don't need suction or oxygen, that's a lot of usage.
Maybe we should just use 2818. That's the bed. That's always variant on staff. But if we just use 2818 as Shane's bed.
There's one person and they don't need, they just need to tucked in at night or whatever.
Yeah, OB or someone could do it. Yeah. I think we need to talk about that a bit more.
Logistically, can you share, because my understanding is, like, I feel like a year ago when we were doing the Sublocade starts, it was on average 5 days. So what's changed in 1 year where we've had such a success rate of being able to do this in such a more timely manner?
So I've had a few patients for whom I knew they wouldn't stay long enough.
I see.
So I had to weigh aggressiveness of putting them into precipitated withdrawal, and benefit of getting them on Sublocade. Now, I'm not going to take credit for the whole thing. I mean, this is province-wide, different people trying different things, and and people get more and more aggressive as time goes on. But I decided on one particular patient here not so long ago, maybe 6, maybe 8 months ago, something like that, I just thought, you know what, if I don't get you on the Sublocade right away, you're just gonna go and overdose again, and you almost died so many times. So I decided to go much more aggressively than I'd ever done before. So previously, it was 0.5 milligram 4 times in one day, stop. Dial out it overnight. Then 1 milligram 4 times a day, stop. Dial out it overnight. And throughout the day. And then day 3, 2 milligrams 4 times a day, stop. Dial out it throughout it. Then day 4, 24 milligrams of Suboxone, and watch, make sure everything's okay, and day 5, give Sublocade. So that's 5 days. And for some individuals who either are triggered or multiple different reasons, 5 days is too much. And I was noticing that 5 days was too much for too many people. So I started changing that. I started giving a higher dose of Dilaudid to start with, and giving the Suboxone at a higher dose to start with. So I go to 1 milligram 4 times a day, but then I don't wait till the next day. I immediately go to 2 milligrams overnight. And then the next day, I give, after they finish the 2 milligrams, I go straight to 16, which is pretty close to 24 milligrams in 24 hours. And immediately upon giving the 16, I know that I'm safe to give them the Sublocade. So I have it thawed out, I have it ready to go, and I now know that I have to say, keep it at room temperature, because it was being kept in the fridge. I also know that I have to describe how to cool the belly so that, with ice, so that the discomfort is less. So I now know how to give those instructions so that we're more likely to be successful. And that's what's changed, is that I've looked at the risk-benefit profile, and I've decided some of the risk was unnecessary risk. Some of the risk is still there, but it's better than leaving against medical advice and never getting it at all. So I balance that, and so now that's how I've got to that point where I go that speed.
I think that's huge, and I think that's a big thing we need to really. That's a big takeaway for me, at least in this dialogue, because like when it was 5 days, we were seeing a lot of people leaving AMA at the 48 hours, 72-hour mark, and we weren't able to complete the full, OAT initiation. So the fact that you found a way to balance that, mitigate the risk, and do this in more that meets the time constraints and the individual need, whether it's trauma-based, whatever the aspect is, that's making someone not want to succeed staying beyond the 48-hour mark, is huge, and it's something that makes me a lot more, I guess, enthused and open to the idea of blocking a bed for it. Prior to that, I was probably a little bit more ambivalent with the concern of the success rate with the 5 days. So I think that's huge, and it's a real testament to your work over the last 5 years. So, congrats on that.
So the idea of getting onto OAT, the idea of filling your receptors and feeling comfortable, the whole idea of that is that whereas previously a person wakes up, they're either in withdrawal or they know they're going to be in withdrawal. So they have to have product. To get product, they need money. They either have money or they don't. If they don't have money, they need to procure money through whatever means they possibly can. Once they've procured money, they get product, they use product, and then they're down. Then they come out of it and they have to do the whole thing all over again. Where in there is the opportunity to work on the emotional, mental health, physical, sexual trauma that they've had that is the underlying pain that is causing them to use in the first place? There's no opportunity, because it's just this, there's no time during the day to work on it. When OAT is successful, yes, we make people feel better, but that's not the end goal. The end goal of it is to give them back their day so they can work on the underlying trauma and the underlying pain, which then predisposes an individual to using.
It's almost like, do we start them off on med surg in one bed, like an 18, but then social work and Ian need to wrap around as well too, depending on the individual, and move them over to psychiatry then. It almost needs to be almost like a pathway or something. Because otherwise I feel like we do it and they go back, we've not dealt with anything except for...
So there are some individuals for whom they have excellent support systems. And as soon as they are stable on OAT, they go back to that excellent support system and they do fine. Alternatively, they move to a remote location, and I do have a few individuals that have done that. They and their partners and their newborn child, who was born during a time of substance use, have been successful on Suboxone or Cadian or whichever, and have gone from there to a remote location purely for the reason of we are away from everything. And they do great, but that's not everybody. So we're talking about the individuals that don't have that opportunity to either have a support system or have the funds or security to be able to move away from their triggers. So they do need a place to go. And there are groups in town that are working on that, and I consult with them to try to help and to be part of their groups to try to find those locations. There are thoughts and there are movements towards having locations, houses, other things that are meant for individuals to either go to after they're stable in OAT, or even to go to for the initial 36 or 72 hours of OAT and then stay there afterwards.
In a non-drug area.
Well, not only that, but also a non-hospital environment
Yes.
area.
Yeah.
Yes.
So
This could be a traumatizing, triggering
Yes.
environment in itself
Yes.
very much so.
for a lot of these individuals.
A lot of individuals will comment that no criticism of the people, but the walls and the smells are residential school. And so they will be triggered by that and not be able to stay long enough for us to be able to be successful. If we go to a place that is nothing like this, kind of like Ty Watson House, but not for palliative care, but for
Why don't you buy
substance
the
use.
Riverside Lodge? That'd be perfect. 8 beds, conference room, kitchen. It'd be perfect.
Oh, you're
I think it's a great idea. Okay? Yeah, I know. I could just move in.
Yeah, stay there.
So those kind of things would be perfect. And my name is down as the physician that will be available for a consult for any of those places, should they become available.
Yeah.
And we do need something like that. We need a place for people to go where they are not triggered.
Yeah.
A place that doesn't include moving back into the crack house where they have not a great environment to try out a new OAT method. So yes, that's a massive part of it. I have these conversations all the time with the fact that people ask, are we doing any good? And it depends. If you mean, are we giving people an opportunity? Yes. If you mean, are we giving them a lifetime of a better opportunity? Well, that depends on the person, and that depends on the situation. And there are situations for whom that's very unlikely. Although, having said that, I have had some individuals who are living in an environment where everybody else is using, and they still come every month to get their Sublocade, and they never use.
Wow.
And they're around it all the time. So there are individuals for whom I cannot fathom how they manage to do this, but they do it. But that's a small number of all the individuals.
Is our following the tugger on Sublocade?
No.
Is Sublocade, because it hasn't come across from the perinatal nutrition specialist in Victoria or from SOGC yet, so what about for the pregnant population?
Perfectly fine.
Perfectly fine. So that would be an option. Because Nanaimo they're working on a house for women to stay in with their babies after and before to get them out of more of a clinical setting. But for sure in here, a lot of times we have a tendency to transfer them out. But Nanaimo holds a lot antenatally and postpartum until they can figure out a situation for mom and babe. So that would be another thing that we could.
But I wonder if we need to have more conversation, like the young girl that we've been trying to get in the last few weeks. And unfortunately, she came in and was sent home. But do we need to have more of a conversation, like, I get she'll be here for a little bit, but then what's the plan afterwards because she's pregnant?
Right.
So I haven't even brought it up with Danielle because she hasn't shown up yet. So, but we need to have more of a plan.
Right.
We have a White Star one too, but she's tapered herself down completely. I don't know how, but that's what Weiser told me. So she's 30 weeks. I met with them last week, but she's not actively using it.
She's not an active user?
No.
Okay.
For the last few months.
Okay. So, sorry, your question was, what
Well, I'm just wondering, like, this girl that came and was sent away, do we need more of a plan? Like, she's here for 3 days, but then what? Where does she go? Like, she's pregnant afterwards. Like, we need to have almost more like a little planning meeting. We bring these people, if we bring them in, it'd be nice to have social work part of it, and maybe Ian.
And that's what Nanaimo's found, is if they get them
Have
off
a
the
little
toxic drug
committee of-
supply, you're helping the baby, like you're growing a baby, because they're keeping them in the hospital, they're feeding them, they're making sure they're safe, and then they're trying to find them. That's why they're building a house in Nanaimo for these moms that they can stay at once they're stabilized on but then they do eat, sleep, and soul in the hospital, and then they go back to the space.
Right.
So anyway, I know it's
I'm not like even just her, she's pregnant, but I'm wondering for everybody, do we have like a little, every
Almost
2
like
weeks, we have like a little,
Almost like our deep
deep
dive,
dive.
but for this
Yeah,
assigned
population.
rooms. So this population, whoever it is that's booked in, that we have some multidisciplinary meeting about, okay, great, we're doing the Sublocade start, we're expecting that'll take, whatever, 24 to 72 hours, but then what other supports can we provide and offer for this person prior to them being
Going.
discharged? I like the idea of something like that, like we do for the deep dive already. I think it'd be a separate meeting, so it'd be different
Yes,
people
yeah.
involved.
because I totally want to support, but we're always in a bed crunch. So we need to find a space that this is dedicated space for this group. And it just keeps moving.
I love the way that Dr. Sarah Lee phrases it about the investment for the neonate. Like that's it. That's a potential 80 years ahead of this person's life that we might be able to impact from the start. Where when we hold beds for ALC patients who are at the end of life, typically, but this is literally an investment in someone's entire life for 80 years coming up. So I liked that perspective.
Yeah.
If we look at it that way. And any gestation is safe in pregnancy. I was looking on the periharm reduction. I'm trying to find it just as injectable. It doesn't say anything.
Low-income housing, these are all the Phoenix House is all full of drugs. It'd be nice if they could clean it out. This is now, Phoenix House is now changed to people who are being supported and treated. I don't know, it'd be nice to change that lens and have supportive housing that's drug-free.
I actually read the recommendations and action plan laid out by the Port Alberni Community Action Team today. That's essentially, that's the whole vision, is that you within 24 hours of interest in wanting to start out therapy, that you'd be able to, it's accessible, whether that's hospital, whether it's an outside facility, but then afterwards there is somewhere for you to continue on that treatment, that's not the end all be all. So it sounds like from that, and I'm sure you are way more informed, but when I was reading the report, there is a lot of movement, like you said, a lot of things going on, but what do we do from our end here while they're here receiving that start? What role do we play in that and in that support? So I think that's something we definitely need to explore and think about.
So the biggest thing I always think of when I'm talking to an individual that is interested in stopping is, what is their motivation? Is their motivation that they want to be healthy themselves? Is their motivation that they want to be healthy for their kids? Is their motivation they want to be healthy for looking after their parents or something? So there's so many different kinds of motivations, and the reason why we're successful is not the same for each one. Some individuals will only change when they see their kids do something that scares them. And then suddenly it's a matter of, I'm changing now because there's no way I want my kids to go through what I'm going through. Or their parents start deteriorating and they can't go visit them because they're out of it like this, and then their parents run into some problems and they say, well, I have to look after my parents, so I'm quitting so that I can look after my parents who looked after me when I was thing. So everybody's motivation is different. Some people are motivated by their unborn child. Some people are motivated by, so all different kinds of reasons. And teasing that out is a really important part. But how we tease that out is a relationship. And that's where the philosophy of care comes in. This is a mental health issue. This is not a lack of willpower. This is not a weakness. This is not. So that's when you approach a person in such a way that this is a health issue that we need to make better, and there's no judgment whatsoever on this. And if it doesn't follow through on the first time, there's no judgment on that either. We do it again. That's where we end up having the benefit. That's where we end up having the success. But teasing that out is the tricky part. It does take the right person and the right nurses and the right individuals to be able to not have that person leave against medical advice. It does not take much. You can have 9 out of 10 individuals be perfect and one individual have them bolt. It is something that does happen, and we've had it happen here, of course. And so making sure that we have the right interactions is important. So when you mentioned the bed 2818 or whatever.
Yeah, that's down here, but I think it's better off in psychiatry.
So that's what I was thinking.
Yeah.
Was because you would really have to schedule the nurses on that certain
I think it's
room
more
to
consistent.
always be in
It's
there.
more consistent
With the staff
there.
and knowing that
And then they can help, they can also start helping, with multiple things, having conversation.
Yeah.
for sure.
Is there with Depo, there's a grace period on either side? Like for the injections, I'm just saying, are you the only one who does them or who's doing the injections?
So I do most of them,
Yeah.
but I do have some nurses that do them. Some nurses that I've trained to do the injections and to do substance use.
And we'll train.
I just think that's a lot on you.
We can train
to have to be there at that 28-day mark. Is there a grace window?
We can train the psych nurses maybe.
Yeah, absolutely. But I mean, as if I'm not in here every day anyway.
I know, but
It's like-
that could be one thing off your plate.
But you should be able to take vacation.
Yeah. So the other part of this though is the relationship building.
Yeah.
So I would love it if there was a number of different foundations of trust, and there are with a number of different nurses in the community and stuff. But I'm the only physician that does this. So I'm and for right or wrong, some patients associate the success with the physician, which is not necessarily something I agree with, but if the patients do it, we need to work with what the patients believe. So sometimes what I'll do is I want to do the injections because I want to use it as an opportunity of having a conversation at the same time. How are you doing on this latest injection? Did you find there was any days beforehand where you felt like some cravings that you needed to use? I know that you had a really hard time with your parents in the last couple of months. Now that things are more stable, have things improved in that way? And I blend it into the greater good of everything else the person wants in their life. So I try to remember what their motivations were, and I try to incorporate the Sublocade or the OAT into their motivations and feedback. How have your motivations been improved with the OAT, which further increases the chance of sustained use of the OAT. So I try to make sure that we do all that. It's not a matter of just giving the shot.
No.
It's a matter of, if I'm only seeing them once every 28 days, I want that once every 28 days to be a reaffirmation of, holy crow, does your skin ever look better?
Yeah.
Wow.
But who does it when you're away though then?
Well, I'm never away.
Well,
so
yes, you are.
So
I've called you before, you've been in Mexico or Hawaii or
I've
wherever.
never been in Mexico.
Okay. we need to show a few people if it's an added skill. I don't know.
Yeah, so I agree with you that it'd be better to have more people.
Yeah.
So who would do it when I'm away? There's one thing to teach the injection. There's another thing to teach the philosophy of care of how to incorporate all these things. And I think that's ongoing.
Yeah.
There are individuals for whom there's some mental health and substance use nurses that I see very often in my office that I know think the same way. That I think if they were to say they want to take on a further role, I would be happy to encourage that and to say that would be a great idea. This isn't a matter of going to school. This is a matter of having the underlying philosophy of how it works anyway. And but yes, that would be really good to have more people doing it. But I just wanted to emphasize that the shot is only gives the opportunity of things getting better, and you have to seize that by then reinforcing it. And really, I do that. Like I'm not just like jokingly saying your skin looks better. I really remember what the skin condition was, what the fingernail condition was, what the clothes and hair condition was, and I comment on specifically what I remember in order to encourage them that, wow, things have really changed. You know how good you look? Look, let's weigh you. You've gained this much. Like, remember how hard it was to give that Sublocade shot? I had to like pinch that flesh and really lift it off because you had no fat because you were never eating. Now you're gaining weight. You're almost at your appropriate body weight. And on top of that, look at your skin. Like, you've got pinkness in it. You're like, and I joke about different things because they know it and they think it, but no one ever says it to them. So then when you say it to them, it reaffirms what they think is going on, which is that they actually are getting better. And so that's a really strong foundation for continuing on with it. That it's not just a matter of, am I down sick or not? Down sickness meaning like no heroin. So no withdrawals. Am I not going through withdrawals or not? Well, that's a subjective feeling and stuff like that. But all the other reasons, how have you talked to your parents recently? Yeah, they invited me to Thanksgiving. I haven't been to Thanksgiving there for 5 years. And then it's a matter of, you know why they invited you? Why do you think they invited you? And then we talk about it, and then it reaffirms to them, yeah, they did. They invited me because I'm doing better. And it builds on everything. So this isn't just medicine. This is way more than that. And this is paying attention to a lot of other things. So I definitely want other people to be involved in that. I want them to think of it the same way. That it is a matter of, this isn't a matter of population medicine. This is individual medicine. This is, now those are completely different things and different conversations, but the individual part of it requires a philosophy. It requires a plan. It requires beds. It requires supports. It requires nursing. It requires possibly somewhere to go to afterwards in order to solidify the benefits. And it's a lot of different things that go into it. I don't expect success every time. No. I don't expect. I fully expect that sometimes I'm going to need to meet people multiple times before there's enough trust built that we can start working on things.
Another question I have for you is, do you do education with other physicians? Because since the harm reduction policy has really come to light, there's been a lot of chatter in the mornings about it. There's quite a few that don't agree with it.
So I gave a talk a week and a half ago, and 4 physicians came.
Do you want to come here in the morning at 7?
If they'll come, sure.
Well, they're here,
but
and they're talking about it.
I think you bring up a really good point, because in general, where we're going to have challenges is if there isn't the buy-in or understanding that the whole purpose is that we're actually just trying to meet people where they're at so that they feel safe and comfortable like accessing healthcare. We want this to be a safe space. And also, there seems to be this false belief that we are either enabling or we're increasing risk of overdose, when ultimately the evidence is actually completely contradictory to that. We are actually opening the door to have a dialogue to someone completely denying that they're using and not willing to engage in a conversation of trust and looking at options of what they define as recovery and also for example, we just had that person recently who originally was completely denying that they were using and was not engaging with us at all, to building trust and rapport, to now disclosing, I am using, this is what I use, I'm about to use. we could be a lot more cognizant and do proper assessments to ensure that, we're not putting them at risk. It also prevents them from, when they leave hospital, from decreasing their tolerance but thinking it's the same, so they go and use the same amount and they're at higher risk of overdose. None of these things seem to be translating with our physician group. There seems to be this big culture and belief that we are completely putting them at greater risk. And
There is a few I hear in the morning that are completely feel that we're enabling, and what are we doing? We're crazy. This doesn't make any sense. And it comes up probably 2 or 3 times a week. So you want to come at 7 in the morning? Generally 7:30. I know you're the kids, but they're generally talking about it.
I know. I mean, they have the opportunity to ask me questions. They have the opportunity to come to talks to ask me point blank what's going on and stuff like that, and to have me tell them how things are different than what they perceive it. But
Maybe I'll
You
just,
should almost
I'll
ask
just
your
play this video
like
in
almost
the
your
morning.
success
Yes.
Like you
Put on
should
a
share
loop.
your success
Yeah.
stories.
and I know that it works. I see it. I know individuals that come to your houses to fix your furnaces and that serve you gas and that are your bank managers and stuff that you don't know it, but they need Suboxone or methadone or something because they previously had concerns. And you guys don't know about it because they're perfectly fine.
Yeah.
I know about it because I'm their doctor, but you guys don't know. So you do know about the individuals staggering down the street. You do know about, a photograph in the paper about someone running through the front door of Canadian Tire and whatever like that. And whether or not that was regardless of the substance involved, you know about those because those are front page news.
Yeah.
You know about the crime reports. You know about the stuff like that, but you don't know about the successes. You don't know about the people who have everything back and who are working on the underlying trauma with counseling and everything else. And those people matter, and those people are the reason why everyone deserves a chance.